Okay, good morning. Welcome to Project Echo. We'll go ahead and get through my quick few intro slides here, then I'll turn it over to Ed, who is talking on the neurobiology of addiction this morning. So our usual intro slides that I have to go over here. This slide here just says that everyone involved in this training has no financial relationships to disclose. And our usual funding statement, we're a grant-funded project. We're funded by a federal grant called the State Opioid Response Grant. Those grant funds come to us through Nebraska Department of Health and Human Services. And again, I see a lot of familiar names. So familiar, same process for CME certificates. There'll be a quick survey at the end of the training. Um, After you complete that survey, your certificate will pop up automatically on your screen. If you have any troubles with that, just shoot me an email. That link will come in the chat today at the end of today's training, and that link will also be emailed to you later this morning. And just a reminder of where we are in our current Echo series. We do these trainings in groups of 4. So we are on the second of the 4 trainings here. Um, Coming up, we've got psychedelics and substance use disorder in 2 weeks. And then after that, our final training from Mary will be the navigating substance use disorder for families in the court system. And then just a quick reminder that we have a group of 6 experts on our team who can do consultations on all sorts of issues related to substance use disorders and pain. So if you're interested in a consult, just give me a call or an email. You've got my uh, contact information there. It's also in the emails you've been receiving from me in my signature line. So don't hesitate to reach out to us and I can connect you with one of our experts who I will let introduce now. I'm going to stop sharing my screen. And I will just call on them to introduce themselves. Let's see. John, would you like to go first?
Good morning. I'm John Massey, and I'm a pain doctor in primarily in Lincoln. Good to be
Thank
here.
you. And Alex.
Good morning, Alex Dworak. I'm a family physician with interests and experience in HIV and Hep C, as well as pain treatments and addiction.
Thanks,
And I'm an
Alex.
Omaha.
And thanks. And Mary.
Good morning. I'm Mary Ellis. I'm a nurse practitioner in the Omaha and surrounding areas, and I'm also an attorney, and I work with families, and I work in the court systems with addiction and treatment and ways to get through the systems so that people can be sober.
Thanks, Mary. Todd.
Good morning, Todd Stoll. I am in Denton and a psychiatrist that's been involved with echo and addiction medicine for a long time.
Excellent. I don't see Stephanie Bennington on right now. She may be joining later. So, Ed, I will turn it over to you.
Thanks, Will. Can you guys see that okay now?
Looks good to me.
Looks good? Okay. Yeah, good morning, everybody. Ed Kaiser here, again, nurse practitioner in Omaha. So family nurse practitioner, started out kind of ER urgent care, and now I've been working with Ideal Option with substance use disorder for the last 6 years, almost 7 years now. So really excited to be with you. So we're going to talk about the neurobiology of addiction. But before I do that, again, I want to express to you guys how encouraged I am by how many people sort of continue to attend our meetings, interested in learning more about substance use, treating patients with substance use disorder. I think as I've done this for a while, I feel like sometimes we're like fighting a little bit of an uphill battle in treating patients and caring for them. And so I just want to say, like, I was talking to Dr. Massey before we jumped on the clinic I used to work for in Omaha closed down a while ago, but I've been very encouraged to be a part of this team and seeing how many people want to help care for this patient population and really help them in the process. So I say all that just to say thanks for being here. Excited to be with you guys today. Trying to get my thing adjusted so I can see my notes better here. Give me 1 second. All right, so learning outcomes for our chat today. at the end of this session, again, be able to understand sort of, and again, this treatment philosophy is kind of what Ideal Option does, but it's a harm reduction. It's sort of a low barrier medication first model. We want to understand the disease process of addiction and its sort of chronic relapsing, remitting course better, which I'm sure you guys are familiar with. Discuss the role of dopamine in the reward circuitry in addiction, and then describe sort of the impact of chronic substance use on that, both the reward circuitry and the brain function. We'll talk about our natural sort of opiate system and how that works, and then the pathophysiology of opiate withdrawal. So again, some of this, it may be review for some people, but I really think it's helpful for us to better understand the patient experience of addiction, and understand sort of the medications that we're using to treat. So I think this is helpful both for the individuals that I sort of educate, and as well as the family members who are walking with somebody through substance use disorder, being able to sort of help them understand what's going on can be a really helpful part of the process. So here's the agenda. Treatment philosophy of harm reduction. We want to talk a little bit about stigmas too. Some interesting things for me there. Impacts of brain genetics, reward and acute exposure, chronic exposure, and then we'll talk a little bit about buprenorphine and MOUD treatment. So, all right, so low barrier harm reduction. The treatment philosophy, again, what I want to sort of stress is, one things that we really want to try to do for individuals is give them sort of timely access to maintenance therapy. So whether that's methadone or buprenorphine, again, without sort of these arbitrary treatment durations or limits. The disease is a chronic disease process, and so patients may need to be on the medication for a long time. Again, we're totally encouraging our patients to be involved in counseling services, group support, all of the wraparound services that are helpful. But again, these things are not required as a condition of medication. You can start people on medication even if they don't have that services, and you're still going to be helping them in the journey of recovery. And then we're only discontinuing the medication if it's causing harm to the individual, or if the patient is desiring to cut back or stop. Generally speaking, patients after about, in my experience, 2 or 3 years of being stable on the medication start to ask the question of like, hey, I don't want to take this every day. And so we help them sort of wean off the medication. When we think about low barriers, again, everything from just like being able to have access to treatment, as well as just the paperwork, the waiting list, eligibility requirements, minimizing physical and staff related characteristics that can stand in the way of people getting their needs met. And so a lot of times patients will come into our clinic and they'll be in active withdrawal. And so if that's the case, having them fill out a bunch of paperwork and do a bunch of stuff on the front end can sort of get in the way of them sort of seeing a provider and getting the medication. So trying to cut down on some of those things. And then harm reduction, just prioritizing reduction in drug-related harm. So obviously morbidity and mortality, but also communicable diseases. And again, highlighting this over abstinence as a primary treatment goal, I think can be helpful just for a mind shift of like, hey, I'm being beneficial to this patient, even if they're not fully abstinent at this time. And then Narcan training and distribution for overdose protection can be important as well. So again, just a more clear definition for you on harm reduction is a treatment philosophy that's aimed at minimizing negative consequences associated with substance use, again, without necessarily requiring abstinence. It acknowledges while complete cessation of substance use may be ideal for some, it's not always really immediately achievable or even desired by some individuals. So practical strategies to reduce harm associated with drug overdose, infection, unsafe behaviors, again, while offering sort of support services and the well-being. The key principles here, again, is just trying to meet people where they're at, respecting their choices and readiness to change. I think that this is a really helpful part of what we really try to stress and do for people. Patients really say like, hey, we're really thankful that you're treating me like a person, respecting my opinion. And I always say in my own mind, like, I can't force anybody to make any changes. They have to sort of decide to make those changes themselves. Again, another key principle, reducing risk, not necessarily stopping use. Again, clean needle distribution is some of that, naloxone distribution, and then just trying to focus on safer practices. Non-judgmental support, try not to stigmatize or punish people for their substance use, support them in minimizing harm. Again, access to health care and resources. And then again, at the end of the day, we're trying to improve people's quality of life, help individuals improve their physical, mental, social well-being, even if there is a continued use of substances for a period of time. I put this slide in here, Stop Overdose Nebraska. So again, just to sort of highlight the access to Narcan and trying to prevent overdose or have that readily available. The little map here shows different places in Nebraska where you can actually go to a pharmacy and request Narcan for any reason. And then on the right side here, you see the vending machine that's available. I think this one is in Lincoln, where patients or anybody can go get it. So this next slide sort of has a more specific, like if you go to their website, this is kind of in Lincoln, there's all these different pharmacies. So again, anybody can go to the pharmacy and say, hey, I want Narcan. And it should be just for, the pharmacy should just give it to you. And I've had some of my peer support people go and actually try this out at different pharmacies. And they do sort of get a weird look sometimes from the pharmacist or from whoever's working there, I guess you would say. But then eventually they were like, oh yeah, we can do that. You just need to like fill out this form. And so, again, it sort of speaks a little bit to the stigma of like, you go in asking for Narcan, people are going to kind of look at you a little bit funny, but we are trying to make it more available, and Stop Overdose Nebraska is doing a good job. So a little bit about stigmas, as I was kind of referring to earlier. Despite sort of the advancements in understanding the neurobiology of substance use disorder, there still remains significant sort of implicit bias against this patient population, both generally and even within the medical community. Patients with substance use disorder often interact with the medical system, particularly in the ED or the emergency department, where they are, possibly in active withdrawal. Those interactions can be challenging, can foster negative associations with the patients. And again, sort of the common kind of drug-seeking behavior. Again, in these environments, I used to work in the emergency department. It can be really challenging at times to sort of maintain compassion in this approach to treating. But again, trying to focus on these behaviors as a manifestation of untreated substance use disorder will help us sort of have a compassionate attitude towards individuals. So again, as we kind of go through our time today, we'll talk about the neurobiology of addiction, and as we better understand that, I think it helps us better care for these individuals. A couple more slides for you on stigmas. Again, a stigma is sort of defined as a mark of disgrace or reproach or a negative attribute that causes someone to devalue or think less of the whole person. The burden of stigma, and this isn't my own material, but it is affected by two main things. And I thought this was helpful for me as I think about it. So one component is the perceived control over the condition. And the other component is the perceived fault in acquiring the condition. So cancer, for example, if someone comes to you or you hear that they, have been diagnosed with cancer, generally speaking, that's a low fault disease process, right? Although there's things that we can do to increase or decrease our cancer risk. Somebody's diagnosed with cancer, you don't think, oh, they did this to themselves. It's like, oh man, that's a bummer. I'm sorry you have cancer. And on top of that, there's a like low control, right? You can go to your treatments, you can take the chemo, but like whether you get better or don't get better is really dependent on if the type of cancer and how early you caught it and things like that. So low fault, low control. If you compare that to substance use disorder, generally speaking, there's this high fault, high control, right? So it was the individual's fault that they got mixed up with the wrong crowd or they started using substances, they brought this on themselves type of language. And then high control, like, why don't you just stop using? Why don't you just try to get away from the people or change your environment, And so again, is the, fault and control component of different disease processes can sort of help drive some of the ways that stigmas manifest. Along with that, stereotypes occur when there's sort of a general public perception that connects labeled individuals to negative traits. And again, the consequences for the individuals that are suffering is in some ways they're discriminated against, feel like they're being treated unjustly, and then again perceived as less valued by others. And so, again, just another barrier that individuals face when they're trying to get help and treatment for substance use disorder. Just looking at a few of the common stigmas. So moral failure or lack of willpower, again, people are wrongly deceived with substance use disorder as this being a moral weakness or lack of self-discipline rather than a medical condition. This is sort of rooted in believing that individuals choose to use drugs and continue to use drugs out of either laziness or selfishness. Again, this ignores sort of the chronic nature. The criminalization of behaviors. I had an opportunity to do a presentation for the criminal justice system last month, and again, there's oftentimes a misconception that people with substance use are inherently untrustworthy or unreliable, and this can lead to like isolation. Now, again, the disease process does lend itself to making some poor choices, so I'm definitely not against holding people accountable for their actions, but trying to view those things more as symptoms that need to be treated. A lot of times patients are believed to be untrustworthy or unreliable. Again, can lead more and more to social isolation, have trouble maintaining relationships, employment, getting trust from others. There's still some stigmas out there that's like once an addict, always an addict, just really minimizing how treatment can really help change people and get their life back. Sometimes we do continue to blame the individual. Kind of talked about that already. Treatment is useful or useless or futile, similar to the once an addict, always an addict. And then the other thing that can happen to individuals is eventually they can develop a sort of a self-stigma where they internalize these things. They start to believe that they're worthless and unlovable and incapable of change. And again, this can sort of cause people to not want to seek help. So, all right, enough about stigmas. Let's transition here to the neurobiology side of things. So, again, when we talk about addiction or substance use disorder, it's a complex condition that's characterized by this compulsive engagement in a behavior that's repeated use of substance despite the harmful consequences that are associated with that. Again, addiction, lay term for what we call substance use disorder. The thing I like to highlight here is that individuals with substance use disorders start out with a normal brain. So their brain is same as everybody else's brain, normal functioning brain. But again, the reward system in that individual's brain gets hijacked by the substance of abuse. And sort of chronic use of that substance results in these persistent changes to the brain chemistry that sort of continue to drive the manifestations of the disease. So compulsive drug seeking behavior despite the harmful consequences. Causes of substance use disorder, it's a combination of behavioral, environmental, and genetic factors. And then again, can't stress enough the chronic nature of the disease process. This is a remitting course, generally can be managed and not cured. I just had a conversation with a patient yesterday. He had been on Suboxone for 5 years. And I think he was just on it like a couple times a day. He had some chronic pain issues. I think he had some bad knees as well. But I was just asking him, hey, what's your goals for being on the medication? And he's like, listen, I have 30 years of addiction in my past. And for the last 5 years, I've been stable and sober. So I've thought about coming off the medication, but honestly, I think I might just be taking this medication for the rest of my life. And so I just discussed briefly with him, like, hey, like that's totally fine. Like we view this as a chronic disease process similar to diabetes or hypertension. And a lot of times for those disease processes, like there's things that we change in our lifestyle, but also a lot of times patients take medications for the remaining of their life. And so that was a fun moment for me because that guy was like, almost felt a little bit relief in him of like, okay, like I don't have to be trying to get off this medicine. I can actually just try to continue to take it and function and live my life. And so I think that's a helpful thing to highlight for patients, both as they're starting and even if they've been on the medication for a long time. So let's look more at the genetic factors and environmental factors. So just a couple of highlighted points here. Genetic risk factors account for about half of the likelihood that an individual will develop a substance use disorder. And again, these genetic risk factors are sort of associated with the common variations of the dopamine and opiate receptors in our brain. On top of genetics, environment, the odds of developing alcohol, cocaine, or opiate use disorder nearly double for every unit increase in the number of ACEs, which is the screening for adverse childhood effects. And so the screening was a little bit new for me, so I put it up on the screen here for you. So I'm not going to read all the questions, but essentially this is like a 10 question scoring. And the first 3 questions sort of relate to abuse questions, whether it's physical, emotional, or sexual abuse. Then the next 3 focus more on neglect, so physical or emotional neglect. And then the last ones are more about like household dysfunction. So substance use disorder, mental illness, domestic violence, separation or divorce, incarcerated family member. And again, for every unit that this increases, it like doubles the chance of someone developing a substance use disorder. So again, just trying to be mindful of those causes, both the genetic and the environmental causes. So again, while the link between genetics and environment with substance use disorder is well established, it's also important for us to examine and review sort of the mechanism by which substance use disorder develops. And so we're going to look at the reward circuitry of the brain here. Again, reward circuitry resides primarily in the limbic system. This is kind of known as the primitive brain, which includes a number of sort of structures involved in emotional, behavioral responses to our environment. Again, the way that this is supposed to work, it's created to work, is to promote life-sustaining activities. Procreation, eating, drinking, socialization is sort of the area of the brain that regulates our ability to feel pleasure in response to behaviors and activities that are essentially necessary for survival, and then it motivates our brain to repeat those behaviors. Again, in a normal, healthy individual, it's supposed to be life-sustaining activities, but obviously substances of abuse sort of stimulate this area of the brain in more significant ways. When we talk about this part of the brain being blind, the other way I like to, or primitive, the way I like to describe it is it's a blind area of our brain. And what I mean by that is the language that this part of our brain understands essentially is dopamine. And again, that's a little bit oversimplified, but it doesn't care about the rules. It doesn't care about behaviors, doesn't care about social implications of behaviors. It really is just focused on reproducing behaviors that create dopamine, again, theoretically for survival and pleasure. All right, so let's look a little bit more at the reward circuitry. So when this area gets activated, the reward pathway, the dopamine is released from the ventral trigeminal area, or the VTA, and that release sort of stimulates an area of different pathways in our brain. One is the nucleus accumbens, which regulates the processing of emotion, aversion, reward, reinforcement learning. Dopamine activation in response to behavior begins this cycle of sort of acknowledging the reward association with that behavior and developing motivation to repeat the behavior, again, reinforcing the importance. Another part goes to the hippocampus, which is involved in sort of creating memory around the behavior and the associated dopamine reward. And then the third track leads to the prefrontal cortex, which again is involved with sort of planning, complex behaviors, personality expression, decision making, moderating our social behavior. So release into this area generates learned behaviors and decisions around sort of repeating the behavior. So again, when this substance of abuse is used, there's a abnormally high release of dopamine from the VTA through all of these areas of our brain. And there's just greater reinforcement and memory associated with that. And again, simply put, the higher the dopamine load release, the greater the perceived both reward and the importance of that behavior, and the stronger the association is with the memory. So there's a slide here that kind of gives you a, visual on dopamine release in the reward circuitry. So again, our brains need a baseline amount of dopamine to survive. There were some studies that were done early on trying to treat substance use disorder in animals, or I think in rats. And what they did is they went in and they tried to shut this part of the brain off. And essentially the animal would just sit there and not do anything. Low dopamine levels, are associated with like low motivation, depression, cognitive troubles, things like that. The most common disease process that we have that sort of shows that is Parkinson's disease, as that goes deeper into the disease process. There's issues with the dopamine and that connecting. So again, most individuals, human beings, for reproducing can release 100 units, have a good meal, 94 units. But as you go across alcohol, marijuana, heroin, methamphetamine, again, the brain sees methamphetamine as 10 times more important than for my survival than sex or socializing or eating or taking care of my kids. And so the blind part of our brain sees like, that must be very important. I need to continue to do that. One final thought for you on this slide. A lot of our patients suffer from polysubstance use. So not only opiates, but also alcohol or methamphetamine. And methamphetamine seems to be one of the substances is like the most difficult for people to get away from and stop using. Even if they stabilize on Suboxone and they're not using opiates anymore, they have a really hard time getting away from methamphetamine. And as you just think of this simply from a dopamine release standpoint, that makes sense why that is such a strong, gets such a strong hold on them. All right, so let's look at the chronic exposure of the brain here. So this diagram demonstrates how with opiates in particular, chronic use results in this cyclic pattern whereby the individual sort of gradually loses their ability to experience the high or the euphoria that's associated with opiate use. So essentially what happens is the need to escape the discomfort of the negative emotional state of withdrawal becomes the driving force for using substances. And again, it seems like a lot of times when patients are willing to go and get help for their substance use disorder, they sort of have gone past this sort of euphoria use pattern and gotten more into the chronic use where they're really just trying to survive and do the tasks that they need to do during the day. I do want to make a distinction when we think about like sort of tolerance and dependence, that just because somebody is dependent on opiates does not mean that they necessarily have a use disorder. So again, dependence is more of a physiological state, where a use disorder is an array of behaviors that are compulsive, leading to sort of social impairment and risky use. Again, someone who is prescribed chronic opiates is going to be physically dependent on their medication, but they may not exhibit the compulsive behaviors of an opiate use disorder. So something to make sure that we are communicating. So neuroadaptations to chronic substance use. So again, in addition to people developing like this tolerance to the substances as well as dependence, there's a lot of neuroadaptations that occur in chronic use. And then again, understanding these help us kind of frame the chronic nature of the disease and how the disease manifests. So repeated exposure of substances of abuse result in high levels of dopamine. In response, the brain tries to remain homeostasis or keep homeostasis, so they downregulate the number of opiate receptors. and downregulates the natural dopamine production. Then when the substance of abuse is withdrawn, these low dopamine states that we mentioned before, it experience a poor mood, lack of motivation, and then this thing that we refer to as a craving. And for us who have not suffered from substance use disorder, it's probably nearly impossible for us to really grasp the consuming nature of a craving. But if you think about it, as we've talked about, the brain trying to survive, imagine with me, just if you've gone without food for 3 to 5 days, how your brain is going to start subconsciously messaging you that you will die if you do not get food, right? Which is true. And then as a result, you're going to be compulsively thinking about food. You're going to be contemplating ways to put yourself in a position to access food. Maybe you would potentially steal food or do something to get food. And so, again, there's this overwhelming subconscious desire to find and ingest food. And that's sort of what the feeling of a craving is. On top of that, we get the amygdala, which is responsible for the fight or flight response, becomes overactive in the absence of substances, and results patients are put in this fight or flight survival state with this singular focus on getting the substance to feel better. And then the prefrontal cortex, regulating judgment and decision making, essentially becomes underactive with chronic use. And again, we can do imaging and we can show on imaging how the gray matter reduction shrinks or is reduced with compulsive nature and chronic nature of the disease process. So again, as we take that all together, the neurobiological changes that happen helps us sort of understand the compulsive nature of substance use, why the behaviors that we see in an individual, whether those are being deceitful or doing compromising activities, that's sort of like those are symptoms of the disease process. And I've probably said this before, but I have so many conversations with patients who are now stable on medication and feeling good and feeling normal. And I ask them about what their life was like before they got in a treatment program, before they were getting the help that they need. And multiple people will look at me in the eye and say, there are things that I've done in my life that in my clear time of thinking right now, I cannot believe that I've done, or I would never do in the current state that I am. And yet I know that I did those in the midst of the sort of the grips of the substance use disorder. And so, again, the individual experience of that is pretty common across the board. All right, so let's talk about opiate use disorder and the buprenorphine treatment. Again, a little of this will be review. So first, we're looking at the sort of the internally produced opiate system, which consists of the opiate receptors and agonists. And one foundational question to consider is why do we have this system in the first place? And again, we've referred to it earlier, but essentially, this system allows us to help us mediate several functions that are important for survival. So the experience of pain and pleasure, a stress response, and then another of other physiological responses included respiratory rate, drive, GI motility, endocrine and immune functions as well. So there's different opiate receptors, 3 different opiate receptors, but the one that's involved specifically in opiate use disorder is the mu opiate receptor. That's the one that gets all the attention. And again, it's located throughout the body. Obviously, it's in the brain, but it's also in the spinal cord, in the large intestines. It's the primary agonist. The primary agonist of the mu opiate receptor naturally produced is the B endorphin, which essentially is our natural sort of morphine. It releases in response to stimuli of injury or pleasurable activities. Binding of the endorphins to the mu receptor results in the responses, including like analgesia and euphoria. And again, the sort of the important takeaway here is the mu opiate receptor that's naturally in our brain is what is the primary target of opiates like morphine, oxycodone, heroin, and fentanyl. And these have the ability, again, to bind very tightly to that receptor and in the limbic system in a strong way and release this excessive dopamine that release or turns into sort of the intoxicated syndrome and state. So what do patients look like if they have acute opiate intoxication? It's kind of important to be able to recognize this, especially if somebody's, in your office that's under the influence. But sometimes patients will arrive either in significant withdrawals, or sometimes they'll arrive in sort of more of an intoxicated state. And again, the sort of most common thing you see is this nodding out, especially if patients are using the fentanyl, where they're, especially if they're waiting for me to show up on the screen remotely and they're in a room all by themselves, they'll kind of start nodding out like that. And even in the middle of conversation, like we're talking about their substance use and they're answering questions, they'll kind of do some of that. And so, again, pretty common to see that. The pupillary constriction is normal. Obviously, respiratory depression is sort of what we're trying to avoid with the Narcan and what is most dangerous. And then again, some people are experiencing the euphoria, the pain relief. Some people get energized; they get more energy from the dopamine, but it also relaxes them. And then also nausea, vomiting can be a common symptom. So as we're talking about neurobiology, let's look at the mechanisms of opiate withdrawal. And again, this is important for providing sort of appropriate management as we're initiating patients onto the medication and if they come in acute withdrawal. So opiate withdrawal is modulated by an area of the brain called the locus coeruleus, or the LC, which is a small group of cells in the brainstem that produces the norepinephrine and the noradrenaline, which is the stress hormone neurotransmitter. So in the occurrence of opiate withdrawal, as a result of the brain, as we talked about, trying to maintain homeostasis, with chronic opiate exposure, the norepinephrine production and the release of the LC increases to oppose this sedation, specifically decreasing the respiratory drive. So it opposes this decreased respiratory drive, and it has this sort of seesaw effect where patients get sedated, and then on the other side, you have the LC attempted to sort of wake them up and keep them upright and breathing. And so when we abruptly remove the opiates and take it away, it sort of upsets that balance, and we get this unopposed, excessive norepinephrine leading to the activation of the sympathetic nervous system, which again directs our brain and body to danger or stressful situations. So with that, under thinking about that, there's this massive physical and emotional stress response to opiate withdrawal. So the individual that is experiencing opiate withdrawal, the severity, the time of onset, and duration is highly dependent on sort of a number of factors. One is, the type of opiate that they're using. So if it's a long-acting versus a short-acting opiate, high or low potency, duration and amount that they've used over time, and then the method of injection. So the faster that the substance can get to the brain, the more potent it's going to be, I guess. So like smoking it versus snorting it versus injecting it, all of that's going to affect how they're experience the opiate withdrawals. Here's the slide in front of you is just sort of this common progression of opiate withdrawals. Again, not going over that in detail, but the main takeaway there is just like, hey, the medications that we're using to sort of target the withdrawal symptoms. Again, hydroxyzine for anxiety, Tylenol, ibuprofen for muscle aches, Zofran, nausea, but clonidine is what I recommend and stress the most to my patients, because again, that's one that's actually not just treating the symptom, but treating the underlying issue with the opiate withdrawals. So again, symptom management is not the standard, although we do use a lot of symptom management treatment for individuals, especially while they're starting on the medication. But again, the treatment gold standard is getting patients on the buprenorphine or getting the medication in their system so that their withdrawal symptoms go away. Okay, so again, just quickly going over just how and why buprenorphine works, or medication-assisted treatment, Suboxone as well. But medications for opioid use disorder are the cornerstone for treatment. They benefit from Patients, again, will benefit from other resources, psychological resources, behavioral therapy, social determinants of health, um, transportation, employment, all of those things. But again, the buprenorphine or the methadone is really the one of the most important components. And again, what it does is it activates that opiate receptor. It gets rid of the actual acute withdrawals, diminishes cravings, normalizes the brain neurochemistry, and then it has the blocking of the opiate receptor in case there's continuing use. And again, just to highlight, we're not doing with Suboxone or buprenorphine is we're not replacing one drug for another. We're not replacing one addiction for another. We're not keeping someone sick in their addiction or substance use, and we're not trying to keep people from finding recovery. We're really trying to help them with the underlying disease. Okay, again, this slide shouldn't be new to you, but the mechanism of the mu opiate receptor, buprenorphine, again, just briefly, turns that opiate receptor on to about 40%, where methadone can turn it on at 100%. It has this ceiling effect. So if you prescribe them a week's worth of buprenorphine and they take all of it in one day, they're not going to overdose from this medication because there's only so many opiate receptors, and those opiate receptors are only turned on at 40%. In fact, the other day I was adjusting patients' dose, and I think I wrote the prescription for 3 tablets 3 times a day, where I meant to write 1 tablet 3 times a day. Thankfully, the pharmacist caught my error and sent me a message, and I got it fixed. But the point is, again, like high amounts of buprenorphine for someone with substance use disorder, the ceiling effect is going to be protective. Again, it is getting harder and harder, but there's enough activation to with the buprenorphine to help the symptoms of withdrawal and cravings. And then again, the higher affinity for that opiate receptor sits really tightly on that receptor, and essentially it blocks other opiates from getting in the system, which again is very, very helpful for individuals who suffer with substance use disorder that have a return to use. If they have Suboxone in their system or buprenorphine, it's really going to decrease the chances of them getting a bad batch of fentanyl or whatever, and overdosing. The ceiling effect, again, just a visual for you, same thing that we just talked about on the last slide. And then as we start to get towards wrapping it up here, one of the knowledge checks is what are the benefits of buprenorphine? And again, sort of mentioned this before, alleviating the symptoms of withdrawals, diminishing cravings, but just highlighting at this point, normalizing brain neurochemistry, right? So giving patients a medication that's a long-acting medication, that's a more stable buprenorphine, more stable dopamine in their system over time as their brain has this at a more stable level versus that picture that we saw where it's going up and down. It sort of normalizes the brain neurochemistry. And then again, the blocking component is really important as well. All right, so a couple of take-home points. Again, buprenorphine, cornerstone of low barrier harm reduction model, evidence-based recommendation for management of opiate use disorder. Substance use disorders, they result in these complex changes to the brain. And again, the baseline dopamine levels and reward circuitry sort of drives the compulsive behavior. So again, as best we can, trying to look at the behavior of substance use disorder as a symptom of the disease process, where if we get them treated appropriately, those behaviors often change. And then again, just a realistic expectation that this is a chronic, relapsing, remitting brain disorder that requires medication, as well as sort of a compassionate care and delivery of that. So further resources for you, and this is the sort of the end of my slide deck time, but I've watched this a couple times, Dr. Montez on YouTube. He does a really good job of going over the neurobiology of addiction much in more detail than I do. So again, he's got a 5-part series, but this resource has been helpful for me historically. And so if you're more interested in the topic, you can go down that route. So yeah, we can open it up for questions, discussions, more comments from the Echo team at this point. I'll kind of stop sharing my screen and we can have any questions at this point.
Yeah, thank you, Ed. Yeah, I'll make sure that link gets sent out as well as this slide deck so that folks have access to that. Yeah, if you have any questions, feel free to unmute or drop something in the chat. Any questions for Ed or any discussions of patient cases, anything like that, feel free to bring those forward at this time. While folks are thinking about that, just gonna say, yeah, there was a comment in the chat that Ed saw from Kelly Fields. She said, "Thank you, Ed, for assisting me with my first time initiating buprenorphine. Appreciate you." Yeah, that's something Ed's helped out with some people, and that's something our project can do. I've heard that it's nice to have kind of someone on the line while you're doing that for the first time or two. And Alex has a case discussion. Um, and I'm not seeing any other questions or um, cases. Here's a question from Clint. We'll get to Alex's in a second here. Clint Jones, I thought there was approximately 16 microreceptors that Bupe gradually blanketed. Does the opioid particle cover them all at once? Any
That's a great
thoughts?
question, and I don't know the answer to that exactly. Does anybody else on the team know for sure? The thing I do know, or at least the way that they've discussed it to us, is like, again, as we increase the dose of buprenorphine from like 8 milligrams to 16 milligrams to 24 milligrams, I think around 16 milligrams, I think it's like 70 to 80 or 90% of the receptors are available. And so, or have buprenorphine available to them. And so I do encourage like, hey, if patients having cravings or feel like they're, having trouble, that last increase of 8 or 4 milligrams is really only looking at like a 10 or 15% increase in the amount of receptors that have access to the Suboxone. And so wanting to not sort of be as scared of the higher doses of that.
And Alex had a follow-up question there for Clint. So maybe we can come back to that one. Alex, if you'd like to bring a case forward, that'd be great.
Okay. Yeah, this is hot off the press. This happened yesterday. I could throw it out to maybe what would the participants do and then what would the faculty do. And then we can talk about what I did, and hopefully it's the same as what everybody else says. So we had a call from our school-based health center. An uninsured kid whose mom speaks only Spanish came in and had been using Percocet, Xanax, weed, and alcohol for some time, and had stopped 2 weeks ago, was what they said. I was feeling bad. Review of the chart documents being bullied, being, the child of an immigrant. And at one point, the kid got in trouble with the law for trying to stab someone. The kid tried to stab someone because this person had murdered their best friend. So I didn't see that exact thing on that average childhood experiences thing, but oh, by the way, the kid's 14. That's my daughter's age. So yeah, our nurse practitioner's like, you got a minute? I had a resident and a patient that no-showed and stuff, and so we scooted the patient on over. We actually have a fellow working with our psychiatrist here, so it worked out perfectly. And then clarifying questions revealed that they had last used opioids around a week ago and were still feeling bad. And they had been using an unspecified amount of Percocet per day. They weren't really sure, but we did a cows, and it was consistent with opioid withdrawal. So what would you all do with this almost 15-year-old? 14 years and 8 months for the pediatricians out there. I
Go ahead
mean,
and
and
feel.
this kid was at a school-based health center. I mean, but not plugged into traditional insurance, and so this could easily be rural too. Uh, working in a federally qualified health center, like the Medicaid expansion has been great. We'll see if that stays, but it doesn't matter if the specialist is hundreds of miles away or hundreds of dollars away. If they can't get to them, that again, there's a lot of similarities between underserved medicine in the city and rural medicine, which so again, this could easily happen outstate too.
Any thoughts from our participants about Alex's patient? Feel free to drop those in the chat, or you can unmute and speak up. We can give folks maybe another minute or two, and then yeah.
Again, I promise I'm not making this up. This happened yesterday. Uh, we, as a policy rule, don't ask because that is will lead to trust issues of people even coming in to get care. And we already have people who are worried that we're going to have agents of the federal government come into our clinic, and there's been some political discussion about that. So, but yeah, kid, I believe, is a birthright citizen, and mom is probably undocumented, but we didn't really get into it. Again, I don't treat somebody differently. I mean, it's good to know what their resources are. You can use Region 6 if you're here in the Omaha area. I think there's multiple regions across Nebraska that hopefully will apply for situations like this. But again, just not necessarily that was part of it, but just to highlight that and the stress around that is another thing that can't be helping. I guess, let's presume that it's Warren Buffett and his grandkid, or like money's not an issue. What would you do medically? Again, polysubstance use. Suboxone's only approved for FDA labeling down to 16 years of age. So kids 14, almost 15, like what can you do?
Well, can I weigh in here? I know
Yes, sir.
so I think we're in full on harm reduction mode here, aren't we? And so you've got the understanding that he's on multiple substances, and one of which is going to be life threatening with respect to you know uh, respiratory arrest, and stabilization is key. Are are you afraid to initiate buprenorphine? I wouldn't be afraid to initiate buprenorphine under the age of 16 in this set of circumstances, because I think the benefits outweigh the risks. And you probably have to explain that to the family members, but if you can initiate control, gain some, get rid of that cow scale, first of all, right? That's going to override all of his thinking at the moment, and then find a way to keep that individual in close proximity to you so you can visit with them again once you build on a little bit of success with that first choice. And bending the rules with respect to the FDA in that regard, to me, would be worth it given the circumstances. Do you disagree, Alex?
Uh, Absolutely not. That's exactly what we did. And this is something that's come up in gender medicine, which is another area where I'm involved. And I have had some trans patients who needed opioid use services because minority stress causes or is a factor associated with substance use disorders to cope, as it turns out. But yeah, so there's been a lot of talk about like, oh, that's like things like Lupron or like off label for this, like, and pediatricians and neonatologists like, do y'all have any idea what is on label in pediatrics? Like nothing. It's almost as bad as stuff that's on label in obstetrics. Like who's going to do that study? Like you're always going to choose non-pregnant adults to get these labeled. So like almost everything is off label in pediatrics. And this is no different. And I agree 100%. If we tell this kid no, he could go out and overdose and die. Because even if he thinks it's Percocet, it's probably fentanyl. And but he's using other substances and using alcohol. Well, great. Should we have him use all that stuff and fentanyl, or all that stuff and buprenorphine? And I'm seeing yeah, comments yeah, like almost nothing is on label in pediatrics, and so just because like he's too young, like that's adult medicine, internal medicine thinking that like having done a ton of internal med training, like it's important to put that aside and say what's right for this patient. Uh, there's also the harm, as you said, of keeping the patient close. If we were like, no, to the patient and the family that they asked for help, and this kid had actually broken down and disclosed this to his mom with my colleague, and so there's this whole like, I'm in big trouble kind of a thing. Like he took a risk, and if we say like, yeah, get out of here, we're not treating you, like that damages the relationship and sets up one of those adverse experiences that Ed was talking about where like, oh, I bared my soul to the healthcare system and I got slapped down for it. So we actually got them in with our fellow that we happen to have. I mean, although if I had seen them, I would have done the same thing. And got them connected with a therapist, which we're fortunate to have here. Mom and patient were in tears with appreciation that they were listened to and that we kind of dropped what we were doing and got this kid care. And I'm like, again, this kid is the same age as my daughter. Like, and I would for damn sure hope that if my daughter came in and said she had this, that she was using drugs, that somebody would drop what they were doing and help my kid. So I'm like, easy decision. But yeah, we 100% started buprenorphine, and with the again, since they're the school-based health center, my colleague, who the kid knows and trusts, is going to be able to follow up closely with them. We can do e-consults and chart reviews because we're involved in the care. We're getting drug screens and all that. But again, we're trying to take the medication first, like stabilize, catch this kid before he falls into respiratory arrest or before he's, a statistic in the newspaper. And was my adrenergic tone a little up because the kid's under 16? Yeah, you bet. But is it the right thing to do? Yeah, you bet. So, thanks.
There's a question, Alex, I think about how will the patient's family be paying for the medication? Do you have any
Yeah.
thoughts on that? Yeah.
Well, so buprenorphine or Suboxone brand films can be pretty expensive. The tablets are actually quite inexpensive. And again, our clinic has both the Region 6 support that we can try to use, which is anything that applies to mental health, including addiction. And then if the kid is, a citizen or legal resident and can qualify for Medicaid, a substance use disorder automatically qualifies you for Medicaid under the current rules of engagement. Our thought was several of us were reading this was that some state senator must have had a loved one with a drug problem because they made like, yep, boom, that's an automatic qualification, which isn't how it used to be. So, and at this point, we also still have an emergency fund that our clinic runs, which is formalized and make sure that we're not like running afoul of the law or anything. We call it the Amber Fund after a nurse named Amber who would, like literally, walk around passing a hat and being like, okay, we're not sending this person home without insulin. What are we going to do? For many years ago. And so we have an emergency plan set up in advance to get people going. If your clinics can consider something like that, it's good to have it formalized and not informal. The patient and their family will need to be covering this, but the tablets are pretty cheap. And as far as timing and follow-up, we're going to follow the kid up within the week. We're, mobilizing our machinery to get interdisciplinary care going. The dose, I would have to double check. And I think it was either 4 BID or 8, but I can look at that real quick when I switch over to my other screen here. And then Narcan is available at no cost, as Ed was saying. I walked into a pharmacy in Omaha and I'm like, hey, I'm a doctor and I have teenagers at home. Like, can I get some Narcan? And they're like, yeah. And I had to fill out the little form. They know me because I send prescriptions there, so they didn't look at me too funny. Then I walked home and I was like, kids, I hold my pink box and my son looks at my, older son looks at me like, Dad, I know what Narcan is. And I'm like, good. Like, yeah, like if one of your classmates is ever like, then like use it on them. I mean, so I think there's a bit just breaking down that stigma and helping people be aware, but also like if somebody has an opioid problem, they and their loved ones need Narcan. That's a great point.
Great. Thank you. Thanks for that case. And thanks, Ed, for your presentation. Looks like we're at the end of our hour here. So there's a link in the chat to do a quick survey and get your certificate. I'll also be emailing that out later today. So look for that in a couple hours here. And yeah, we'll be back in 2 weeks. Stephanie will be doing a talk on psychedelics and substance use disorder. So hope to see you all back then. Thanks.